See what we got. $74. 48. You good with 45 to start?
Yeah, just a second. Okay, so it looks like we've got about 50 people on right now. We'll give it just a couple more minutes for people to join, but I think that'll probably be enough for us to go ahead and get started. What I wanted to do today, first of all, let us know in the comments if you can hear us okay.
And you guys can start firing off questions at any time.
Okay, good. So they can hear us well. Thank you, everybody. Wanted to just briefly update everybody on what the current status is in the system. And so for that, I'll go ahead and pull up this dashboard, which I think you guys have probably seen already. This is the Florida COVID-19 dashboard. I don't know why it's not loading the county right now, but you can see the total cases in Florida, as well as hospitalizations and deaths at this point. The other interesting thing to bring up is our prediction. This has changed a little bit. This is the modeling out of the University of Washington, and we used to have a peak about here around May 4th or 5th, and now they're bringing the peak back to about the 21st for us. So that's moving up our timeline a little bit, peak in 2 weeks from today. Still showing an estimated not quite 7,000 deaths in the state of Florida, bearing in mind that the confidence interval here is this range here. So the 67, 68 is the estimate, but that number could be as low as 3,600 and as high as 11,000. So just bearing in mind that's the confidence interval there. Again, you can see that there's maybe a small second wave here. Not sure what that's about yet, but that's what the modeling is showing now. So a little bit different from what you might have heard before. Jasmine, I don't know if you want to mute or something, but I can hear other people there talking. So let's see. Let me find the stuff from this morning if I can. And I'll try to give you guys a quick rundown of what we're actually seeing in the hospital. Currently in Pinellas County, it looks as though we have 20 patients in the ICU with COVID-19 and 13 patients on ventilators with COVID-19. So that gives you some idea of what we're actually seeing. In the last 24 hours, 2 patients were admitted and 4 were discharged with COVID-19. And again, there are 20 some odd people hospitalized who are not currently on ventilators. So we do certainly have some impact of the disease here in town. It's not huge yet, but 15 or 20 people on a ventilator is nothing small either. And so there's definitely some impact to us. Still remains to be seen how significant that impact is going to be, but that's our current situation here. The other thing I wanted to share with you guys is a lot of discussion in the last couple of days about how to best manage these patients and how they actually are best treated and how they look. And the concept of the hypoxia is one that it's worth maybe just spending a few minutes on. I think it's maybe an important distinction that's starting to be made between hypoxia, which would indicate hypoxia at the tissue level, inadequate tissue perfusion with oxygen, and hypoxemia, which would mean inadequate oxygen levels in the blood or bound to hemoglobin. And there's some early idea, and again, this is just a speculative theoretical hypothesis, that the virus actually messes with the heme molecule in your hemoglobin, and that is why they're showing so hypoxemic, meaning low oxygen level in the blood, but not necessarily hypoxic, meaning poor tissue perfusion. So one doc that I was on a call with earlier today mentioned that he had seen somebody with a SAT in the 40s who was mentating clearly and looked pretty well. And so that's obviously concerning and unusual for us. And I think just reinforces how we have to treat this disease just a little bit different. Continuing to hear that fluids need to be restricted for these folks to do well. Positioning of the patients, proning them, having them help recruit their own alveoli, and make their VQ matches as good as possible is also starting to be something that's talked about a lot. La Femme, people are actually starting to talk about proning. We have a sort of an old rule in EMS that we never transport somebody on their belly. But in this case, I wouldn't mind, particularly if you moved them from side to side or whatever you could do to make their respiratory distress better by positioning. I don't have a good protocol for actually how to do that yet, La Femme, but certainly if you wanted to have them roll from side to side every few minutes, that would be good. If they can be comfortable on their belly for a minute or two, that'd probably be okay. I don't think I would like to leave them there. That sort of goes against our normal stuff. And that has to be done. When that is done in the hospital, it's being done in the ICU under a very, very guarded scenario. So that's sort of what I'm hearing. I'm hearing zinc is probably still important. I'm hearing a lot about proposed mechanism of action for hydroxychloroquine, right down to really geeky stuff about raising the pH within the endosome of the cell that's infected with the virus to essentially slow down the cellular machinery and decrease the amount of virus that gets replicated. So there's lots of stuff going on right now. There's also a link that went out to all of your chiefs a little while ago. There's a study being done by the University of Minnesota where they're enrolling volunteers from among the first responder and healthcare community to prophylactically take hydroxychloroquine and see what happens. The data on that drug is still very early and iffy, and there may be some reasons why it works, and it may have some good efficacy, but we don't know that for sure. And there certainly are side effects, whether that's your QT interval or there's some retinal issues that you can get from it. There's some bone marrow suppression kind of things as well, I think. So it's not without any kind of risk. So that's what So Dr. Lozano happened to chime in. I think he probably heard some of the same stuff I heard when they talk about proning. They're doing it for a couple hours at a time. Again, it's about recruiting more alveoli and eliminating the VQ shunting that's happening. We don't know yet whether it would work if we did it in the ambulance. There's one or two folks in the state of Florida that are considering putting that into protocol from what I hear. We don't have a plan to do that quite yet. What else? I think that's basically what's happening. In case you guys didn't see, IAFF and IAFC put out something today about wearing surgical masks in the station and when you're out in public. So look out for that position paper or statement if you'd like. Up to Billy says, once on event, what's the survivability? I've seen different numbers between 50 and 80% mortality once on the vent, which would say 30 to 50% survivability or 20 to 50%. But I think we're learning a lot about this thing, and I hope that number will go down. I'm not sure that we've seen quite that high a number here, but we certainly saw numbers like that out of Italy. My hope is that what we're learning from Italy will actually help us to reduce that mortality here in Pinellas. So that's the hope, or here in the U.S. So that's the hope, is that the more and more we learn from other places, the more we can do better here. And I think with the permissive hypoxia, with the limping them through on either high flow nasal cannula or CPAP or BiPAP in the hospital, I think the mortality rates may start to come down, but again, that remains to be seen. We're still pretty early in all of this. Chief Tedesco says, would you please speak to the concept of medical treatment does not stop because of COVID-19? Chest pain is still chest pain, et cetera. Yeah, that's a really important point, Chief. And I've tried to emphasize that a couple of times. And I've even mentioned to you all that anecdotally, we've had a couple of cases where we got distracted by the whole COVID thing and sort of failed to take normal steps on some of these patients. And unfortunately, that was maybe not the best thing we could have done. So I think it is really, really important that, so first of all, the treatment guidance that we're putting out in the next couple of days. And again, I had hoped to have it out today and live tomorrow morning, but I think it's probably going to be live Friday morning with out on Thursday. We had a couple of last minute edits that needed to be made and a couple of things that we needed to do to make sure that it's as up to date as possible. So we're nearly there. We'll have it all for you. The important point there is that the treatment protocols in condition yellow are specific to suspected COVID patients. So there's no change in standard of care for any other patients. And even when you have a COVID patient, as long as you're taking the mitigation effects and using the COVID specific strategies in that document, all other protocols remain in force. And so we do need to focus on doing the best clinical care we can, regardless of whether or not it's a COVID patient. Right now, we are well resourced. Call volume is down. PPE supplies are very sustainable right now. The hospitals have low volumes. The ERs have plenty of capacity. So there's no reason why we can't be giving these patients the absolute best chance at survival, whether their issue is COVID related or not. And so under condition yellow, the normal standard of care has not been changed. Who is texting me? Somebody doesn't like my background. I can turn it off. But next one is Lusher. Hello, Lusher. How much weight do we put into published death numbers when the CDC is stating that hospitals, pretty much any death is assumed to have caused or contributed to death and lab tests are not required? So I think that's the case in communities where you have very, very widespread disease like Italy, like New York. I don't believe that's the case here in Florida. Certainly not yet. That's not the case. We are being very specific about having any hospitalized patient be tested at this point. All right. Any news on when we'll start wearing full face mask versus N95? Okay, so if you didn't hear that on the Thursday call, or last Friday's Q&A session, I'll repeat it now. The fire departments are moving fairly rapidly towards the full face respirators. I think there's one agency, possibly Dunedin, doing half faces. But in general, the fire departments are moving towards full face respirators with P100s because they are much more sustainable. You can use them on many, many calls as opposed to the one call with the N95. So that's in progress. Fit testing is going on. Repeat fit testing is going on at lots of agencies. These are sized masks. You have to have the appropriate size of the full face respirator. And so that process is underway at multiple agencies. And I believe that most of the fire departments are moving towards that this week to get people into those masks. I will tell you that we still do have a pretty good number of N95s in the warehouse. I'm not going to tell you exactly the number since this is a public forum, but we do have enough for right now. And the changes we asked you guys to make over the weekend with putting the procedure mask over the N95 mask and then potentially reuse it have already started to have a good impact. So I think we're in a pretty sustainable position for the moment for our PPE, but we do need you guys to balance protecting yourselves, which we certainly want you to do, with not unnecessarily using PPE. We are also going to start to see yellow bags to collect these things for potential reprocessing and re-sterilization for reuse. I do not know whether or not we will reuse them in the EMS system or whether we will get them cleaned up and share them with our hospital partners or what that will look like. But sort of all strategies are in place to preserve and make PPE last longer. I think you'll still see some people wearing N95s. That's whether they can't properly be fit tested or, for any number of reasons. I don't think we'll necessarily ever get to 100% full face respirators, but that's the current plan is to start moving at least the fire departments to the full face masks over the next few days. Shell says, has the age range changed as far as groups most effective or most affected? Yeah, it's definitely getting a bit younger than the initial coverage in the news and reports from China. The idea that this only affects old people, I think, has been fairly well debunked at this point. It is clearly something that's affecting more people than we thought in a broader age range. Obviously, underlying diseases makes it more likely for you to have severe disease. But there are plenty of people who are relatively young and healthy who are not doing well with this. The COVID-19 disease itself has some very strange features to it. We're still seeing people presenting with GI complaints and diarrhea in some percentage as their first symptom. We're also seeing people who do fairly well for a week or longer and then suddenly get much, much worse. So it still remains a bit of an elusive kind of a disease course. Stephen, excellent question. So any updates on testing our personnel and wondering about the blood tests that have been mentioned in the recent news? So I do have 2 updates on that for everybody. Update number 1 is we do have the capability of testing EMS personnel within the system. We can swab you ourselves and send that to the DOH lab, and the DOH has promised to expedite it and give us a 48-hour turnaround. So we do have a supply of nasal swabs for you. And if we have a symptomatic member, we will arrange for that person when appropriate to be tested. That will happen through your agency coordinating with me, who will then coordinate with the folks who are actually going to collect the swab at Sunstar headquarters. And then that swab gets couriered over to the lab in Tampa for priority handling for a 48-hour turnaround. So that's number 1. We do have the ability to test people as we need from the system. So if you have an exposure or well, not if you just have an exposure, but if you're sick, if you become symptomatic, we are able to test you. You will not have to try and go to Raymond James or wherever else and get tested. So we do have that ability. And that just needs to be coordinated through your agency, who will then coordinate with me and the folks who will be swabbing you and the DOH, and we'll get it all taken care of. So we've done that a couple times already. We anticipate we will be able to continue to have that resource available for the foreseeable future. So I don't think we need to worry about being able to get people tested when they are actually sick. I think we do have that nailed down at this point with a 48-hour turnaround. As far as the blood tests that are mentioning in the news, I am very happy to report that we placed a large order for those tests today. And I do mean large. And I am currently working on a plan to be able to test every single first responder in the county multiple times over the next few months with both the IgG and the IgM rapid point of care test. So we are working up a protocol and we are working up a procedure on how that will be done. But I'm very happy to let you know that we placed an order for a very large number of those tests today. It will probably be a couple weeks before they're here, and we will do this through with some data collection to make sure that we have appropriate follow-up of any results, and to make sure that we can learn as much as we can from this, and to make sure that other EMS systems can learn from this as well. So Stephen, great question, and really excited that we're going to be able to do that. I think we're probably going to be able to do every firefighter, medic, EMT, and probably every law enforcement officer, at least from the sheriff's office, and maybe some of the city PDs as well. The plan is to test folks basically every 2 weeks once we get it up and running, and keep an eyeball on exposures. Also have some indication if perhaps you've been exposed or maybe even had it before and didn't really know it. And also might help us a little bit in finding asymptomatic cases, so we prevent that from spread, but that's probably a secondary or tertiary kind of benefit. We will share out the protocol and the procedures for this as soon as we get them all finalized. And again, it'll probably be a couple weeks before that's up and running, but really excited to be able to tell you that. Next is there any firm guidance for those with milder symptoms or even fever, very sick, or treating at home so as not to stress the system, put first responders at risk, and when to call 911? Yeah, so Pinellas County Marketing is actually working on that messaging about who to call, what to do if you think you might have COVID and you're doing pretty well. We will not stop responding to calls until we get probably to condition black. And we will consider turning on home care for COVID, where, we go and assess the patient. If they're low risk and looking pretty good, we'll do some shared medical decision-making to leave them at home. We'll probably not turn that on until condition red. Right now, our hospitals are only at about 50% occupancy. I'll tell you, in the hospital right now, it's almost eerily quiet. And yes, I said the Q word. Hopefully that doesn't jinx us too bad. But it's been that way for a bit, and we're all sort of holding our breath like, ooh, when is the wave going to get here? But right now, I can't justify not responding to people or telling people not to be assessed. So that's where we're at with that. Chief Tedesco, what about the lab machine and the cartridges that go in to test the sample? That's a slightly more complicated test, Chief. It involves reagents and diluting and all that kind of stuff. Okay, so now hang on. I've got the second comment that says we don't like the background. So the background is going to go away. Okay. Tried. Guess it didn't work. The test with the machine, Chief, is a little bit more complicated. It involves taking a blood sample and then doing some other stuff to it before you put the drop on the cartridge and put it in the machine. That takes a little while. The tests that we're getting are point of care finger stick tests. So like checking a glucose, you put a drop of blood on it and you get a result within a few minutes. Dr. Smith said, the background is fine. Can we do anything about your face? No, there's nothing I can do except grow my darn beard back when this is all over. Thank you, Dr. Smith, for that. So, Josh, read the virus possibly damages a third of the hemoglobin. It provides reason for the O2 sat. Yes. Yeah, that's exactly what I was saying about hypoxemia versus hypoxia, and why the guidance that we'll be putting out in the next day or two talks about essentially permissive hypoxia is the word we're using, but it's really permissive hypoxemia or permissive low oxygen saturation. And so that's one of the working theories right now about how this virus is actually, in some ways, a hematologic issue as opposed to a primary respiratory issue. So there is some percentage of the population that gets a cytokine storm in the lungs, and that ends up with an ARDS, acute respiratory distress syndrome, multi-organ system failure type picture eventually. But then there's this whole other segment of the folks with COVID-19 who look a lot like high altitude pulmonary edema, in that they have these low saturations, but they may still be somewhat functional from a tissue oxygenation standpoint. And then secondarily, they have a lot of edema in the lungs. And we're hearing more and more that you really need to run these patients on the very dry side. Any excess fluids will cause a real quick deterioration. Yes, I said the Q word, Chief. Sorry. Okay, so somebody or a group of people from St. Pete Beach say, what are the chances of using those tests as part of the refusal algorithm? I'd say none. That test doesn't really help me in terms of clinical care. It helps me in terms of screening you to know about your potential exposure. So it checks for IgG and IgM. IgM spikes when you're acutely infected, and IgG is your memory, immunologically speaking. It's your antibody or immunoglobulin that keeps you safe longer term. So that one comes later after the initial infection. But it would be really interesting to know how many of our people have some IgG to this virus already in them. It might be helpful for your peace of mind, although it certainly would not mean you don't need PPE, but it might be helpful for you just in terms of well-being and ease of mind. It also would be potentially interesting to see if we find people with IgM, meaning acute infection, who are asymptomatic. And wouldn't it be nice to be able to identify that person and then send a viral swab to figure out, do we really need to ask that person to not come to work and be isolated because they're one of these, some percentage that are asymptomatic carriers. So that's more the utility of this test. In addition, documenting how this virus is actually impacting first responders and what kind of risk we are at compared to the general population, I think is also very, very valuable for this. So that's what the test would be for. It would not be for use with our patients in the field. Yeah, the iron interfering with it's really the heme molecule is the hypothesis that it's messing with the heme molecule, which is that iron-based molecule, and messing up its ability to carry oxygen. And that's why you're seeing these people with super low oxygen levels, but there's still some reasonable tissue oxygenation going on where they still have a good mental status and not super in respiratory distress. I'm hearing from some docs up in New York that they're having people with SATs in the low 80s who are like, hey, can I go home now? I feel fine. I want to go home. Uh-oh. I think we lost Jasmine, but that's okay. Hopefully you guys can still see me. Pop up in the comments. We may have had a technical difficulty. Let me know if you guys can still see and hear me. And in the meantime, Joe, okay, good. Thank you, Chief Kern. So in the meantime, Joe, yeah, there is some evidence that, oh, Jasmine is back. There is some evidence that there's direct cardiac damage as well. That's been talked about as a marker of very, very poor prognosis. So when you get direct involvement of the virus infecting and destroying the cardiac tissue, that's obviously when things would go bad as well. You'd end up sort of cardiorespiratory failure. LaFemme, yeah. So the idea is that you're going to see SATs that make you uncomfortable, and that patient may or may not actually be hypoxic at the tissue level. So they may have a good mental status. They may not be super struggling from a respiratory standpoint, but their SATs could be in the 80s or lower, and their work of breathing could be not terrible. And so that's the idea. That's the idea, is that we need to be aware that this messes with what their SATs look like, and not freak out if they have a low SAT, even if they're mentating well and don't appear to be in distress. And that's why the protocol is going to allow for permissive hypoxia with a goal saturation of 85% or better. So we'll do supplemental oxygen to hopefully get them up to 85, but we're not going to automatically intubate that patient just because their SAT is 85. We do much better, it sounds like, from the limited data we have, to let them ride it out at 85 and bring them into the hospital. Chief Culverhouse, sorry if you already touched on this, but if you test positive on one of the rapid tests, wouldn't you still need to be tested via standard testing? Potentially. And so the protocol would probably look like something: if you pop a positive IgM, you would probably get sent for a nasal swab to confirm it, and decide whether or not you have to be in isolation while you're potentially an asymptomatic transmitter. But if you popped an IgG, no, you wouldn't necessarily need a confirmatory test, because a confirmatory test would probably be negative if it's just the memory, because that indicates a previous infection, not a current infection. Hopefully that answers the question. All right, that's all the questions I see so far, so keep them coming. We're half an hour in. I'm going to spare walking through the protocols again today, because they're going to get finalized over the next 48 hours. And by the time we get together on Thursday, I should be walking you through the protocols that will go out with a medical control directive that afternoon, and will go into play Friday morning. And I think most of you all, at least if it's the same people that were on here last week, have already heard me walk through them. So throw up any more questions that you have. I'll do my best to answer them. Let's see, anything else? Nope, no active protocol change since the last update. We will get you that front and back side placard of condition yellow here just within the next day or two. As you can imagine, things are changing fast, and we want to try and have it be as up to date and complete and consistent with the best knowledge that we have right now as possible. And it will be going through medical control board on Thursday morning. Stephen, we will definitely put them up, but we probably won't put them up till Thursday when they're finally official. Okay, so currently mandatory closest facility on possible COVID against patient request. So I don't know that we have that in writing anywhere officially yet, but it will say closest appropriate facility once everything goes live on Thursday or Friday. The reason for that is that, we want to minimize your exposure, your time of exposure in the back of the ambulance with them. So stand by on that one, Kyle. In the meantime, certainly do an online consult if you have any question about what's appropriate. Josh, that would be interesting. If it does release the iron, because I've noticed an increase in GI bleed type patients. That's super interesting, Joshua. I don't know whether that would necessarily cause increased bleeding issue. It might cause anemia type issue, and obviously the oxygenation type issue. Not sure whether it would in and of itself cause more bleeding or anticoagulation, but an interesting theory. I think there's a lot of things on the table right now that we just don't know the answers to. How many strands are out there, and does the test we have test for all of them? Yeah, so the mutations of the virus are generally close enough so that they don't, that they're still cross-reactive on the rapid tests. trying to look up a good image of the strains here for you real quick. There was one map that showed the actual strains and how where their mutations were and branch points, but it's kind of complicated, but it's cool if I can find it here. But yeah, there do seem to be multiple strains. See if I can find you a good. So I've heard of maybe up to 8 strains, but again, I'm trying to find the an actual graphic that shows you that. Well, hang on. Here it is. For those of you who are MCRIT podcasts listeners and stuff, this is on the MCRIT site. And let me just get to it. Uh-oh. Hang on. Okay, maybe you guys can see this. Jasmine, can you see this? This crazy diagram? Is that a yes? You're muted, I think.
I'm unmuted.
Okay, can you see this?
Zoom problems here. Yeah, it looks good. I can see it.
Okay, so this is how crazy the genetic mutation drift is, and this is the this is it looks like 2 spider webs exactly, and so what's crazy about it is if you actually read through this was the original L and S types, and you can see there's sort of hubs each place and different little strains in each place where it's tested, and so there's two different sort of ways that viruses change their genetic makeup. In general, you can have little substitution errors, or you can have big old chunks. And so like one's like a typo and the other one's like a cut and paste error is I think a good way to think of it. And so when you see a big old change, that's when you probably see a difference between one dot and a whole different dot, like one of these red ones and one of the blue ones. And then when you see just a couple of typos, you'll see from one blue to another blue, I think is probably a pretty good way of describing it. So every virus is constantly mutating. And it's only when you get like a big significant one that you get a new, like clinically different potentially virus. So that's why this is the SARS-CoV-2 virus as opposed to the SARS-CoV-1 virus that we had previously. This is like the COVID spaghetti model, but not. We actually had a COVID spaghetti model I shared before, which I on one of the previous podcasts. Maybe I don't know. Is it still on your desktop, Jasmine? Can you show that? Do you have it handy?
I don't know if I still have that one.
I thought it was great. I forget who sent it to me. But anyway, so yeah, there are multiple different strains of this virus. I think the L and the S are probably the most common ones that people are talking about. But there are potentially even more than that. Any updates on causing neurologic symptoms? I've heard a lot of people get severe headaches with it, but I haven't heard of any focal neurologic symptoms going along with this. And then for why do some EDs deny entry to EMS on arrest patients? Well, that's not supposed to be happening. So although if they want to do the handoff at the door, I guess I'm not super opposed to that. Is that what you're talking about, handing off at the door, or are you talking about like not letting you actually take the patient in? That diagram, I don't know the original source of it, but it was posted up on the MCRIT site. So you should be able to find it there. That's emcrit.org. It's a blog and educational site for critical care emergency medicine. All right, next is, did you have a rough time frame for when the testing will start in the county? So the order that we placed today was the quickest one we could find, and it was, they said 3 to 4 weeks for delivery for the finger stick tests that we would have you guys doing maybe every 2 weeks, I think is the initial plan, but that could change, obviously. So 3 to 4 weeks is about what I'm hearing right now. And that was the best one we had. Some of them were like, yeah, it'll be here in 6 or 8 weeks. And we're like, well, that's kind of not so useful. So that's the best I've got right now. Fire St. Pete, right? Something, I don't know. Fire Sprite. I'm not sure if I'm saying that right, but again, it's MCRIT. I'll put it in here right now. .org, I believe. You can find it there. Rando 2262, to your knowledge, is PCSO enforcing the stay-at-home orders? Would being out and about with no excuse or reason for not essential be grounds for a Baker Act? Good luck with that. No, it might be grounds for a summons or a ticket or something. You'd have to ask the sheriff directly, but I know that they are doing a lot of work to get people to follow that. And I'm on the executive policy group for the county with the sheriff every morning, and I know they are doing just a ton of work related to that. He was going to be presenting a report on what they've done so far to the Board of County Commissioners today. I did not have a chance to see that, but I'm sure you could find it on the County Commissioners website from the meeting today. But no, I don't think that would be grounds for a Baker Act. The FEM, what do you mean? Do you want notification in denial for arrest patients? What do you mean? Do you mean like if we don't work somebody because we're in category black and we think it's a COVID patient? Is that what you're trying to get at? So while I'm waiting for him to answer, the next question is, do you think this will change healthcare, particularly PPE protocol in the long run? Raymond, so this is a great question and a great a great a great reminder of the fact that we're supposed to be wearing all this stuff on every flu patient anyway. That's what the RIP note during flu season is for. And the fact that we've been lazy about it and not do it the way we should. And I mean, all of us in healthcare, not just EMS or not just the ER, but everybody, the fact that we've been so lackadaisical about it over the last couple of years is sort of laughable at this point, but true. And yes, this should be a wake-up call that we should be wearing proper PPE whenever we're taking care of somebody with a potentially communicable disease. Because again, even if you do fine with it, maybe you're symptomatic, maybe you have the flu for a couple of days and then you're better, you could easily pass that to somebody else who is not going to do as well with it. And that's the whole idea of the self-isolation thing. It's only in small part to protect yourself. It's mostly about protecting other people, about protecting those who are at higher risk of having problems. LaFemme, I think we lost you, man. I don't know if I answered your question or not, but. And then at Bobby DC 41 are all the death numbers. So I think you can be confident in the death numbers out of Florida that they are truly COVID tested and associated with COVID. I think maybe in other places, and I think I might have mentioned this before, that in other places where the numbers are really out of control, that that there may be some assumption in there. But for right now, I think you could be pretty confident that they are truly COVID cases if they're listed as deaths here locally. So okay, different question from La Femina. Like waiting significantly long at an ED destination with a patient on a stretcher outside the ER. So I think a little bit of working well with our neighbors is probably important right now. You will see, and how's 120 seconds a long time? You've been working that patient for a while already. Let me double check what the EMS hospital handoff plan says. Ambulance bay / ramp or vestibule entryway transfer of patient care for all patients except behavioral health, cardiac arrest, STEMI stroke, trauma alerts, which shall be transferred into the nearest room per ED staff. So the plan is to try to have a spot for you to go, but I'll be honest, I've seen it at other hospitals, not necessarily in Pinellas County, where we do the handoff even for a cardiac arrest patient out front. And I'm not totally opposed to that, but our plan currently is that they should be finding you a room to go directly into for those high priority patients. So if you are having issues, yeah, let us know about it so we can address it. But also, remember that this is new and people are trying to do the best they can. I would not advise retransport to the next hospital after 119 seconds. I think that might be detrimental to your patient. All right, what other questions do you guys have? Fire away or we'll wrap it up because we're going to have probably a longer one on Thursday when we get those protocols out. Nothing? Okay. Well, the meme challenge from 2 weeks ago kind of tapered off. But I think I've got one for you, maybe. I think this is the best one I got. I hear Jasmine going super. I don't think Jasmine had any memes that she was going to share of her, but somebody made this one of me, and I thought it was pretty good. That was the COVID cone of uncertainty behind it in the picture. So I'll just leave that up for a second while you guys think of your last questions. Kyle, any ALFs in Pinellas affected yet? I would say that we do have a case or two in or from some of our long-term care facilities, but only very small numbers so far. So we don't have any major outbreaks in any of our long-term care facilities, whether that's a skilled nursing or assisted living or anything like that right now. Scott says patients with GI symptoms always progress to respiratory or can run its course as mild GI. I don't know the definite answer to that, Scott, but I think mostly they will at some point develop respiratory symptoms. It's just the early symptom may be GI. All right, that's enough of that meme. Thank you. I forgot who sent that. I'm sure the person will take credit. Raymond says, what's your gut feeling? Do you foresee it becoming a New York situation here? Do you think there's a good chance it could stay in the condition yellow? I hope that we don't go to black, and I don't think we'll go to black only because we have done so many people have spent so much time and work preparing us to make sure we don't run out of PPE and things like that that would push us to condition black. I think there's a reasonable chance we could go to red, but I do not have a crystal ball. And the real question is whether our social distancing stuff worked over the last 2 weeks. And that is a tough one because it takes at least 2 to 3 weeks to see whether there was any effect from that at all. So, oh, sorry, somebody else was chiming in or no? Guess not. So hard to know yet, Raymond. I really hope we don't go to black. I think there's a reasonable possibility we could go to red. It would be great if we stayed at yellow the whole time. As I've said before, if we make it through this whole thing with all 2,000 of us in the system, if we make it through this whole thing with none of our people getting severely ill or God forbid dying, I think that that we will have a real success there. And I can't tell you again how many people are working night and day to put us in a position where that would be possible. I believe two. I want to say I got to confirm this, but I think I heard that 2 sheriff's deputies in Florida have already died from COVID over on the other coast. Certainly, plenty of first responders have already died up in New York City from this, and in other places in the world. And I do think it's important that we all, be cognizant of the risks that we're talking about. And I've heard a couple of times recently, and so I think it's worth mentioning. I've heard a couple of times recently that somebody didn't know what was going on. They didn't know what condition we were in. They didn't know what kind of mask they were supposed to wear. They didn't kind of have a heads up on where we were with all this stuff. And I cannot tell you enough. I cannot tell you enough that you got to pay attention during this time. When we put something out, you have got to read it because it's about keeping you safe and it's about keeping you off a ventilator and it's about keeping you alive. And so, we want to do good patient care, but we also want to make it through this without losing anybody. And, we're trying to make stuff as simple and consistent and easy to digest as possible. But at the end of the day, we're all adults here. We're doing difficult work and you've got to read this stuff. You've got to pay attention. When we put out an MCD on Thursday, that thing should be read by everybody within, 24 hours tops. This is the kind of stuff where you got to take a little responsibility to make sure you know what's going on. I can't spoon, we as a system can't be spoon feeding people and expecting them to stay safe. People really, really, really need to take, some initiative here and make sure that they understand what we're asking them to do to stay safe. So for those of you that are paying attention, thank you. Tell a friend, make sure that everybody's up to speed and encourage people to really be on the ball on this one. I am worried that we could have some tragedy here if people aren't paying attention. So I would just ask you to really, really focus in on what's happening over the next couple of weeks as we get to that peak point. Lusher says how critical the next 2 weeks as far as distancing, general preventive measures as a whole. It could not be more critical, Andrew. Could not be more critical. The thing we worry about a lot is a second spike or a second peak with all those folks coming into Florida from other places like, say, New York and New Jersey. I have a lot of concern about whether we're going to get a second peak. So we really need to keep up that social distancing until we're on the back end of this thing, until we have better information about how many people have actually asymptomatically had it and recovered already. I'm hearing from a couple of sources that the asymptomatic rate could be up to 50% of the people infected. And if 50% of the people walking around with it don't know they have it, there's almost no way to prevent, things getting worse without really aggressive social distancing. Because if you don't know you have it and you still go to the grocery store or whatever else it is, people are still getting infected. So that's one of the reasons why the social distancing and the staying at home is so very important. Which Bobby DC 41's Charlie, which curve are you talking about? Were you talking about the one that had the peak date on it? So just confirm for me, you're talking about this one. If you're talking about this one, I think you can see the link up at the top, but I'll paste it into the comments, and it has for the whole country as well as for Florida specifically. Okay, if there's no other questions, I think we'll wrap it up there. So I'll just give you guys about 10 or 15 seconds to put any of your last in. Okay, here we go. It's just under 2 months from hurricane season. What's the game plan if we have tent-based field hospitals and need to also put a lot of citizens into shelters during a named storm? Oh boy, I hope that doesn't happen. I hope that this thing is on the backside before we get truly into hurricane season. But we are talking about that. At this point, I'm not anticipating any tent hospitals in Pinellas, although that could certainly change. Um, but all the hospital surge plans that I've seen so far are into actual structures as opposed to tent-based field hospitals. Shelters would be a real problem if we had to concentrate people in shelters right now. So I really hope uh, that we can not have those two things happening at the same time. I keep hearing about asymptomatic people having lung damage being found on scans at hospitals for unrelated issues. Can you be asymptomatic with lung damage happening? Theoretically, I think you can. It depends on how healthy you are and how much reserve you have. Kind of like a young healthy person could tolerate a little bit of a pneumothorax or pleural effusion without much in the way of symptoms, but somebody who has less reserve would not tolerate that at all. But most of the time, I think there was something going on with that person that prompted the CT scan in the first place, whether they were getting like a PE rule out because they were a little hypoxic or something else like that. Anthony says, what's the difference between airborne and droplet? Is it airborne or N95 is okay? Yeah, so that is kind of actually the difference. For airborne, you need eye protection. So you need to protect your mucous membranes and you need to have an N95 as opposed to just a surgical mask. And it looks like that's about the last questions. We've been at it for the better part of an hour. And so again, I'll just give you a few seconds to put in any last questions. We will be coming back and doing this again on Thursday afternoon is the plan. And at that point, we'll have the actual final protocol documents for you that we would anticipate to be working off of for the next 2 to 4 weeks as we go through the surge. So it looks like no other questions. And with that, I think, Jasmine, unless you have anything else. Oh, okay. So I guess I'll go ahead and say thank you all for attending and stay safe out there. Really, please be careful. Do not get complacent with your PPE. All right. Take care.